Okay, let's go ahead and get going. That'll be a record for us.
Now we got our She's comical today.
It just never quits, does it?
Okay, let's go.
What, next Tuesday, you have a test.
Yes.
Yay! 12, 13, 14, and 16. We're going to skip 15 and come back to it.
So what was it?
12, 13, 14, and 16. Because 15 is immunology, and it fits in better, respiration fits in better with what we're talking about now. So 12, 13, 14, and 16. So however far we get today, we will finish 16 on Thursday, if we don't get through it today. Okay?
Do you know what's going to be on the final?
However far we get.
Okay. Are you going to go in order according to the syllabus?
I want to do immunology,
That's interesting.
and because, when I look at what you're going to be getting into as nurses, and that's something you absolutely need to have a basis in. Reproduction, and I'm not sure whether I'll just go lightly on a couple of chapters or just simply skip a chapter. So I'm going to talk to Mary, but I'm not sure which one of those I'm going to do yet.
She usually skips a chapter.
Yeah, I know. But why would I deny you all that knowledge and the opportunity to be tested on?
I know. You're so thoughtful.
I got to enjoy this job sometime. Okay,
Torture.
this is vascular resistance to blood flow. How many of you here are a physics major? Mechanical engineering? Hydro engineering? Okay. We're going to go through this pretty quick. I'm just going to we're going to talk about the basics. If there's something I think you need to know for the test, I will tell you that you need to know this for the test, because I'm not about to teach a physics class here. A lot of this is very much a physics type equations. What we'll do is we'll just get the general theory on the resistance to blood flow and how it happens, and we'll go from there. So you can get into a lot of detail, and you can have, the hydrodynamics of blood flow. You could spend a semester on it, and still come out saying, what the hell is that? Cardiac output is distributed unequally to the different organs. Know that the different organs need different amounts of blood, depending on their metabolic activity. And if they need more blood, they're going to have more capillaries, and you're going to have unequal resistance, i.e., if they have more capillaries, more blood is going to flow through that organ easier. The ability to get oxygen and nutrients into that organ. Give me an example, an organ that just absolutely has to be maintained.
Has to be what?
Maintained.
Oh, your heart.
The heart,
Your brain.
the brain,
Kidneys.
nope,
The liver.
nope.
Lungs.
Lungs, because of the need for the perfusion to the other organs. But those are your three main ones. In your fight or flight syndrome, your blood gets shut down to the skin, it gets shut down to the kidneys, it gets shut down to the intestines. It stays up in the liver, it stays up in the heart, it stays up in the brain, it stays up in the lungs, excuse me. The lungs, because you need them to oxygenate blood. The liver, because you need the circulation through the liver to get glucose into the bloodstream to continue feeding the skeletal muscle, the brain, and the heart. The heart, obviously, because of the fight or flight syndrome, the coronary, the epinephrine is released from what? Medulla. Okay. So should I put that on the test? I mean, I've only asked the question every lecture for the last 4 or 5 lectures. Yeah. I can put that one on the test? Okay. Anyway, cardiac output it's not equally distributed. Here you can see distribution of the cardiac at rest. All right. GI tract and liver, 1,400 mils per minute. Kidneys, 1,000. They're filtering. Skeletal muscles, 1,200. Heart, 250. Consider the size, the amount of muscle in the heart. The size of a grapefruit versus the skeletal muscles. Brain, 3 times what the heart gets. Not much bigger. 5,800 mils per minute. That's a resting heart rate. Physical laws. Blood flows from a region of higher pressure to a region of lower pressure. The blood is pushed out of the arteries at a pressure somewhere, average pressure of about 100 millimeters of mercury. By the time it gets through into the arterioles, down into the capillaries, and through the capillaries into the venules, you're down to 3 or 4 millimeters of mercury. When the higher pressure blood hits the capillaries, it's not only going to be pushing red cells through the capillaries, exchanging glucose and nutrients, absorbing, releasing oxygen, absorbing carbon dioxide. It also will push fluid into the interstitial places. And then, because of the albumin and diffusion back, most of that fluid is picked up either back into the capillaries or in the lymph system on the other side of that capillary bed. Rate of flow is proportional to the differences in pressure. If there's a huge difference in pressure, you're going to get faster flow. But by the time you get down to the capillaries, and there's not, because your arterioles are down to about 15 or 20 millimeters of mercury. So it's not like you've got 100 millimeters of mercury on one side of a capillary and 2 on the other. You blow them out. But coming out of the heart, in the main arteries, you're up around 100 millimeters of mercury, but by the time it dispenses throughout the body, it goes down. Now the other thing, so here's mean pressure coming out of the heart, and as it goes out, gets through the veins and gets, the pressure goes down so much that you need what type of pumps to help get the blood back up to the heart? Think bigger. What kind of pumps do you need to get the venous blood back up to the heart? These pumps plus the what in the veins keep it from flowing back down into the feet? The valves. Valves in the vein make the veins a one-way direction for blood movement. But how does it get back up to the heart? How does it get up into the vena cava, carotid veins? Skeletal pumps. Skeletal pumps. You're walking around, you're doing exercise. Your muscles are contracting, you're squeezing the veins, they're forcing the blood up. The valves in the veins keep the blood from flowing back down. That's why even, perfusion, blood resistance may actually go down during exercise because your muscles are working so hard that they're keeping it moving back up into the vena cava. Okay, rate of blood flow is inversely proportional to friction, resistance, and blood flow within the vessels. Got it?
Seriously?
No. This is where you get in, your blood flow. I'll try not to hit you with the laser. Your blood flow, and the smaller the vessel, the more resistance to blood flow. The more friction with the side of the vessel. Don't write it down. This is part of the physics that I'm not going to question now. I'm not going to have you going through equations, calculating blood flow and resistance through a vessel. Okay? You know what you hit. No, you don't have to know that. You do have to know that the smaller the vessel, the greater the resistance to blood flow. The larger the vessel, the less the resistance. That works for your veins. That works for your arteries. What else does that work for? Yeah, but I don't have a lot of copper piping in it. What else in the body does that? No. That probably works for me in the GI tract. No, that's not what I'm thinking of. What about your nerves? What about your thick nerves versus your thin nerves?
So smaller, more resistant?
More resistance. In nerves and in blood vessels and in arteries, veins, the smaller, the more resistant. And then the nerves, you have the myelinated and unmyelinated. But your big nerves are all myelinated. But just the diameter makes it much more efficient. That's why even outside, you see the high power lines? They're big, they're thick. Because the thicker they are, the less resistance even for the electricity going through a high power line. Resistance, okay. Physical laws, again, what it's saying here is the smaller the opening, the harder it is to push blood through. You're allowed to ask questions, okay? If you have a question, go ahead and ask it. Okay. Physical laws regarding blood flow. Just the take-home message is the smaller the vessel, the more resistance, the harder it's going to have to work to get it through. Okay? But your blood's leaving the heart into the aorta at about 100 millimeters of mercury of pressure. By the time it gets down into the capillary beds, it's down to 10 to 15, maybe 20 millimeters of pressure. And then by the time it gets through the capillary beds, you're down to about 3 millimeters of pressure. And then you have your skeletal pumps that are really, and the valves that are getting it back up to the heart. This 3 millimeters of blood pressure isn't pushing blood in. Okay, blood length and blood viscosity normally do not vary much. Mean arterial pressure and vessel radius are therefore the most important factors in blood pressure. How much pressure there is and how big the vessel is. We just went through that. Okay, vasoconstriction of arterioles provides the greatest resistance to blood flow and can redirect blood flow from particular organs. This you do need to know. You need to know that when your fight or flight syndrome starts, that your parasympathetic system or sympathetic system. That's the other Japanese. You need not to test us in that. Here it is. It's back. Sympathetic system, fight or flight. Parasympathetic, rest, recuperate, relax, repose. Your fight or flight. You ever scared somebody so bad they turned white? What's that? Oh, okay. It happens. It happens. Your body can shunt that blood. Also, they have an anastomosis. When the body is turning off blood to the intestines, to the skin, some of the capillary beds, an anastomosis is a connection between the arteries and the venules. It skips the capillaries. It happens when you get real cold. Your body is going to shunt blood into the deeper part of the body to keep it warm, to keep your internal organs at operating temperature. This is via anastomosis between the arterioles and the venules. It's skipping the capillaries. The blood that's still in the capillaries turns kind of rosy. That's why you come in from the cold, you're nice and rosy cheek, but it isn't because your capillaries have dilated to cool. It's because the blood that's in the capillaries is just kind of staying there. And if it stays there long enough or it gets too cold, then it starts freezing. You start getting frostbite. And then your skin's starting to die. So don't do like the old days in Minnesota, rub it with snow. Doesn't help, only hurts. Don't come in and put it in hot water. That only hurts too. You damage the skin. Okay. This is just a diagram again. The blood pressure coming out of the left ventricle, large arteries, and then you go to the small arteries, capillaries, venules, large veins. Large veins have almost no blood pressure at all. That's why you need what kind of pumps to get it back up in the number?
Skeletal.
Good. Total peripheral resistance. The sum of all vascular resistance and systemic circulation, blood flow to organs. Now this is something that, this could be on the test. The blood goes from the aorta, it doesn't go from the aorta to the intestine, to the kidney, to the liver, to the skeletal muscles, and then to the, when you get blood to a capillary bed or to an organ, you have an artery, arteriole, and capillary bed that feeds that organ. It doesn't come from another organ and move into that organ. With one exception, 2, 3 exceptions. Your venous portal system. You have it in the liver, you have it in the brain, and you have it in the lungs. In the liver, you've got the portal system. It's taking venous blood from the intestine, getting it into the liver because it's picked up all these nutrients in the intestine. You have it in the brain with some of the hormone regulation, and it's a portal system that goes through the pulmonary vein and artery also. But other than that, your arteries run in parallel. You're not pushing blood, or you're not pushing oxygenated blood from one organ to another. When it comes into the organ, it's freshly oxygenated. It hasn't gone someplace else, and you're getting secondhand oxygenated blood. They run in parallel. Vasodilation in a large organ may decrease total peripheral resistance and mean arterial pressure. If an organ is sucking up the blood, it's going to lower it someplace else. And the body is going to compensate for that, either by cardiac output or vasoconstriction. Now, we already told you got about 5.5 liters of blood. If all your veins are opened up and your capillary beds are opened up, you don't have enough blood to fill them all at one time. So at some point, for your non-essential capillaries, or capillary beds, the blood gets shut off once in a while. You mentioned the kidneys. We can take a kidney out and keep a kidney on ice for a couple of days and then transplant it. And it'll reperfuse and it'll start going again. It can very much handle a low oxygen level, low perfusion. Can't do it with the heart. Haven't tried it with the brain. But, yeah, is that the doctor? Frankenstein was a monster. Who was the doctor? I just keep it thinking of Gene Wilder, but that's just,
I don't think that's it.
that's just not a good thing. Okay, anyway, blood flow runs parallel, vasodilation in a large organ. When the blood goes someplace, it's got to be made up someplace else, either by increased cardiac output or vasoconstriction. Okay, extrinsic regulation of blood flow, autonomic and endocrine control of the blood flow, sympathetic nerves, fight or flight, increases total peripheral resistance through the release of norepinephrine into the smooth muscles of the arterioles, in the viscera, in the skin, to stimulate vasoconstriction. Remember, fight or flight, the blood is going to go to where you need it. The brain, the lungs, the heart, the liver, and the skeletal muscles. It's going to take it away from the skin, the intestines, the kidneys. They can all do without it for now. Acetylcholine is released into skeletal muscles, result in increased vasodilation to these tissues, due in part to the adrenal epinephrine. The skeletal muscles, from the sympathetic in fight or flight, you need the oxygen, the glucose to the muscles to run or fight. Extrinsic control of blood flow. You have your androgenic, the alpha and beta androgenic nerves, vasoconstriction for the alpha, and some activity with the beta, masked by beta will give you a vasodilation. That's more of your parasympathetic system. Cholinergic, what do we mean by cholinergic? What's the neurotransmitter for cholinergic? Acetylcholine. Parasympathetic nerves, vasodilation. What's your big parasympathetic nerve that goes all over the body? Vagus nerve, the wanderer, the wandering nerve. It goes in exercise, fight or flight. It goes antagonistic to the sympathetic system. So in exercise, your heart rate goes up. At the same time, your vagus nerve is firing up to help keep it in control. A much finer tune on the heart rate and other body activities. Angiotensin can be a very powerful vasoconstrictor. ADH, vasopressin, again, a vasoconstrictor, not an antidiuretic hormone. What does it do? Controls blood volume. How? Anti.
The anti, right, but if, depending on how much is in there, so with the...
Anti.
Makes you hold on to hold on.
Yeah.
Makes you absorb more water, lower urine. Antidiuretic. A diuretic would make you urinate more. This is an ADH, an antidiuretic. Along with the renin-angiotensin system, which causes you to reabsorb more salt and the come along or contaminant water that comes in with it. Renin-angiotensin doesn't change the osmolality of the blood, because when it brings the salt back in, it brings the water with it. But they both act to maintain or increase blood volume, which increases blood pressure. Histamine, vasodilation. You get an allergic reaction to poison oak, you get an allergic reaction to a bee sting, what happens? Swells up. The histamine, vasodilating, dilating the blood vessels, the capillaries in that area, and it's swelling up. Allergic reaction, you see the histamine. Bradykinins. They're released by the sweat glands. They cause vasodilation. When the sweat glands kick in, the body is trying to cool itself. The bradykinins are going to dilate the capillaries so you get more blood to the surface so that it cools and you maintain a core body temperature. Prostaglandins can go either way. Remember, you have prostaglandin 1, prostaglandin 2. One works as a vasodilator, one works as a constrictor. Again, they fine-tune an antagonistic reaction, as you see throughout the body. Parasympathetic nerves. Acetylcholine, vasodilation. Parasympathetic doesn't do a heck of a lot. You let little blood back to the digestive tract, genitalia, salivary glands. It really doesn't do much. Your body will take its time recovering from the fight or flight. You live that long. Whatever you're fighting or flying from. Paracrine control. It's back. Paracrine, as opposed to endocrine, as opposed to exocrine. What's paracrine? Oh, it's right up there. Molecules produced in the tissue control the same tissue or within the same organ. Paracrine acts close by, in the same organ. Tunica intima. Where's the tunica intima? Did I say internal? I said intima. As opposed to internal. In the walls of your veins and in the walls of your arteries. No, the tunica intima is not in. But you know what? This is where your fat deposits get laid down. In the walls of your veins and your arteries, excuse me. And that produces what? Disease. Atherosclerosis. But you get paracrine influence and you get endocytosis. You get a bruise. You get a little bit of disruption in the membrane. You get an endocytosis. It picks up the fat globules, gets into the wall, into the membranes, and all of a sudden your atherosclerosis is on the way. Smooth muscle relaxation is influenced by bradykinin from where? Sweat glands? Oh, yeah. Nitric oxide, prostaglandin. Like I said, you have two types of prostaglandin. One produces vasoconstriction, one produces vasodilation. They're an antagonistic reaction, again, much finer control. Nitric oxide, this is back again. Produces vasodilation. There's a couple of drugs very commonly used that take advantage of nitric oxide. Nitroglycerin, absolutely. You have angina pectoralis, you've got poor blood flow to the heart muscle. Give them a little nitroglycerin. You've seen them do the paste. You get somebody who's got angina. You know, technically, I don't know what they taught anybody else when they taught me in Red Cross. They said, don't take the nitroglycerin and put it under their tongue, because you can get sued for practicing medicine without a license. You hand it to them and tell them to put it under their tongue. If they can. Little bit. Bradykinin, nitric oxide, prostaglandin. Another drug with that uses nitric oxide, Cialis, Viagra. That's how it works. But also, they use it for pulmonary hypertension.
That's what it was originally developed for. Wasn't it? Viagra was originally.
I think it actually was developed initially for pulmonary hypertension, but they found other benefits. Endothelial 1 stimulates smooth muscle contraction to produce vasoconstriction, and that's a hormone. And I wouldn't spend a lot of time worrying about endothelial. Intrinsic regulation of blood flow. Used by some organs, brains, kidneys, promote constant flow when the fluctuation of blood pressure is also called autoregulation. Myogenic controls vascular smooth muscle response to changes in arterial blood pressure. Where are the sensors? Carotid arteries, arterial loop. Metabolic control mechanism. Vasodilation is controlled by changes in decreased oxygen concentrations due to increased metabolism, increased carbon dioxide concentration, decreased pH due to CO2, lactic acid, CO2 with carbonic anhydrase is turned into what? Carbonic acid? Yeah, thank you. I worked on that. And we will get into that more when we talk about the oxygen dissociation in chapter 16, because the lower the pH, the easier it is for oxygen to dissociate from the hemoglobin. Release of potassium and paracrine signals. If the tissue, the lung, or not the lungs, mainly the kidneys are censoring a poor blood flow, they're going to do what they can to ensure their blood flow. Bottom line, in the end, it's going to be the brain and the heart that are going to get the blood. But intrinsic regulation as tissues or in the carotid sinus, you're looking at pressure, or the carotid veins, you're looking at the pH. If the pH is low, you have acidosis. If a buildup of CO2 is turned into carbonic acid, what's the body going to do to get rid of that CO2? What's going to happen to your respiration rate? It's going to increase. Your respiration is going to increase. You are going to blow off more CO2. Remember when we did that lab, when you jogged and then came back and blew into the bottle, the time it took for the phenolphthalein to change went way down. A lot more CO2, a lot more carbonic acid. Okay. Yeah, I think so. Now it'll probably blow your ears.
Chemoreceptors in the carotid and aortic bodies monitor blood oxygen, carbon, and pH. Impulses from these chemoreceptors are conducted to the control centers for heart and blood vessels via the glossopharyngeal and vagus nerves. In the medulla oblongata monitor blood carbon dioxide and pH. Decreased blood oxygen in the carotid and aortic bodies monitor blood oxygen, carbon dioxide, and pH. Impulses from these chemoreceptors are conducted to the control centers for heart and blood vessels via the glossopharyngeal and vagus nerves. Chemoreceptors in the medulla oblongata monitor blood carbon dioxide and pH. Decreased blood oxygen, increased carbon dioxide, or decreased pH decrease parasympathetic stimulation of the heart, which increases the heart rate. Decreased blood oxygen, increased carbon dioxide, and decreased pH increase sympathetic stimulation of the heart, which increases heart rate and stroke volume. Increased sympathetic stimulation of blood vessels increases vasoconstriction.
Depending on the blood vessel. Okay, blood flow to the heart and skeletal muscles. Coronary arteries supply blood to a massive number of capillaries, 2,400 to 4,000 per cubic millimeter. You go back to your skeletal muscles, you might have 3 or 4 or 500 per cubic millimeter. A lot of blood goes right back to the heart. Unlike most organs, blood, when the heart contracts and you're in systole, it pinches off the veins, it pinches off the capillaries to the blood, to the heart, excuse me. So this is where, your heart is this nice, deep, dark red. It's full of myoglobin. The myoglobin that's in there provides the oxygen during systole. In diastole, the blood is flowing through the capillaries again. Cardiac tissues has a lot of mitochondria, respiratory enzymes, and very metabolically extremely active. Coronary arteries can increase blood flow about 5 times in exercise. Regulation. Norepinephrine from the sympathetic nerve stimulate vasoconstriction, raising resistance at rest. Adrenal epinephrine stimulates vasodilation and vascular resistance during exercise. You have, again, an antagonistic system that's regulating the blood flow to the heart. And then you have the vasodilation enhanced by intrinsic metabolic control mechanism, i.e. looking at the pH, the CO2, the O2. Regulation to the skeletal muscles. Arterioles have a high vascular resistance at rest. Skeletal muscles are going to receive 20 to 25% of the body's blood supply. So your arterioles are not wide open when you're at rest. Not to the skeletal muscles. That's why when the sympathetic system kicks in, fight or flight, it opens them up. And to do that, it has to shut down other areas because you don't have enough blood. If it didn't do that, your blood pressure would drop and you would just faint. And be sabers with tiger food, whatever. Vasodilation is stimulated by both adrenal epinephrine and sympathetic ACTH. Intrinsic metabolic controls enhance the vasodilation during exercise. Again, when you start exercising, you have anaerobic metabolism for the first 20, 30, 40 seconds. And then everything dilates and you've got aerobic metabolism and burning up the fatty acids in the muscles, but also the intrinsic metabolic controls. The intrinsic, again, pH, CO2, O2 are going to act if the muscles If the O2 or the pH is dropping, it's going to vasodilate, it's going to let more blood to the muscles as long as that works, as long as you've got enough. At rest, your blood flow to the skeletal muscles, 1,000 mils a minute. Androgenic sympathetic stimulation of alpha receptors. Remember, alpha receptors are vasodilators, as opposed to beta receptors that are not nearly as powerful but are vasoconstrictors. Beginning of exercise, the dilation of arterioles and skeletal muscles. Some beta androgenic receptors by the hormone epinephrine. You're going to channel your blood. Heavy exercise, fall in alpha androgenic activity, but an increase in the cholinergic, sympathetic activity, increased metabolic rate of exercising. Muscles produces an intrinsic vasodilation. Produces vasodilation because, again, of the intrinsic metabolic products. Circulatory changes during exercise. Vascular resistance to skeletal and cardiac muscles is decreased. Now, vascular resistance, this is a great test question. Does the flow go up with vascular resistance or down? If vascular resistance is decreased, is the flow to the muscle up or down? If vascular resistance is decreased, the flow to the muscle is up. It's easier to get blood and oxygen and that to the muscle. Okay? Besides that, you have increased cardiac output. Your heart is pumping faster. Your stroke volume goes up. It's pumping more mils per minute per stroke. Per heartbeat, it's pumping more blood. Vasodilation, again, the diversion of blood away from the viscera and the skin, away from the kidneys, away from the intestines, away from the skin. Blood flow to the brain increases a small amount with moderate exercise and decreases a small during intense exercise. Now think about this for a second. If you remember, when we talked about neuroregulation, that at some point you get a neural response. You get tired. But it's not tired because your muscles are weak or running out of myoglobin. You get tired because your brain and the neurons are starting to be exhausted. This is where they think that comes in. You're using this much more exercise, but intense exercise, your actual blood flow to the brain goes down. And so you may get some, and I'll think of the word in a minute, but in the later. But essentially a neural exhaustion because of lack of blood flow to the brain during intense exercise. Fatigue. Thank you. That may be it. But it'll work. I mean, that's good. It works. But you see where I'm getting at. Moderate exercise, plenty of blood to the brain. High exercise, it gets cut back. There's a fatigue.
So is that why I'm able to blank out when I'm running? Or is that just, is it related to that? Because the only time I can do it is when I'm running really.
No, I think that's probably more of an endorphin and concentration thing. I'm not being sarcastic.
Oh, no,
Cardiac can increase about 5 times due to increased cardiac rate. Up to 3 to 400, that'd kill me. Stroke volume increases some due to increased venous return. What do we mean by stroke volume? One stroke is the amount of blood the heart is going to pump out in one beat. But remember, during the cardiac cycle, you have the rest, the relaxation, the ventricle is relaxed, the atrium is relaxed for a fraction of a second, the blood is flowing in from the veins into the atrium. It's enough to push open either the bicuspid or the tricuspid valve and flows right down into the ventricle. Part of the cardiac cycle, the atrium contracts a fraction of a second before the ventricle, shoving whatever blood's in the atrium into the ventricle. Well, like we said, with this vasodilation and the increased activity of the skeletal pumps, your venous return to the heart in heavy exercise is generally a lot better. So not only does the atrium fill, it's filling the ventricle, it's filling a lot quicker and a lot easier than in a normal resting state. So when it gives that final little push and the atrium contracts, you get a little more, a few cc's more blood in the ventricle before it, shoots it out into the aorta or into the pulmonary artery. That's your stroke volume. That increases. Not only does that increase, your heart rate increases. So the amount of blood pumped per minute from the heart can increase by about a factor of 5. Okay? This is just, this is in your book. You're talking here 5 liters a minute, all the way up to 25 liters a minute. And this is where it goes. 3 to 5% goes to the intestines. So what's happened here? At rest, you only got 5 liters a minute, but 20 to 25% is going to the intestines. Up here, you got 25 liters a minute, only 3 to 5% is going to the intestines. This is what we've been looking at. Your intestines don't need a lot of blood when you're in heavy exercise or in fight or flight. 4 to 5% is going to the heart, 4 to 5%, but 4 to 5% to 25 liters a minute, or 4 to 5% of 5. So this is still 5 times what it's getting down here. Kidneys, 20% during rest, a relaxed state. Up here, 2 to 4%. Bones, 3 to 5, 0.5 to 1. Brain, 3 to 4%, 15%. And then the skin, zippo. And the muscles, 80, 85%, 15 to 20%. This is where the blood's going in your fight or flight syndrome. These are the organs that are going to keep you alive. Cardiac output, increase. This is during exercise. Cardiac rate. Cardiac output, your stroke volume is up. Your cardiac rate is up. Your cardiac rate is increased. Stroke volume is increased. Total peripheral resistance is just decreased. Your vessels are open. You're getting blood and oxygen out to where it needs to go. Your arterial blood pressure increases. Your diastolic volume is unchanged. Blood flow to the heart and muscles is increased. Visceral organs, liver, kidneys, decreased. To the skin, during exercise, if you exercise and it's increased the skin for thermal regulation, not in the fight or flight, but in thermal regulation. Blood flow to the brain, 750 mils a minute. It just doesn't change that much except in real heavy exercise. Brain cannot tolerate much variation in the blood flow. Mean arterial pressure becomes very high. There's very little sympathetic control of blood to the brain. At high, there are stretch receptors. At high blood pressure, your vessels in the brain constrict to protect the small vessels. As we said, you've got this large amount of pressure coming off the capillaries, coming through the arteries, the arterioles, to the artery side of the capillary bed. If your blood pressure goes way up, you do not want to blow a capillary in the brain. Well, an aneurysm is actually when an artery blows. But you start blowing the veins or the capillaries, you're still going to have a CVA, cerebral vascular accident, or a stroke. There's two types of strokes. One where your blood pressure is really high, and you blow a capillary or a small artery or arterial, generally capillary or arterial in there, and that's about 20% of the strokes. 80% of the strokes are because you've thrown a clot and you've actually occluded the arterial or the capillary bed or part of the vein where you've stopped the circulation into that part of the brain.
So what happens when you're pregnant, when you have the whole high blood pressure at the very end, and they'll do C-section because they want to...
That's actually preeclampsia or eclampsia, and that's extremely critical. Preeclampsia they'll control with drugs or try to, if it gets away from them and you go into eclampsia.
Are they trying to prevent a stroke?
Yeah, pretty much. Yeah. Your blood pressure goes way up, they're going to go in and take the baby. They're going to get it out because it's going to hurt the baby and it's going to hurt the mom. Preeclampsia, again, they'll treat with magnesium, mag sulfate, and a couple other things to try to bring the blood pressure down. But vasoconstriction, your brain tries to protect itself at high blood pressure. The brain will constrict the vessels, try to maintain it, minimize any damage. When blood pressure falls, cerebral vessels dilate. Blood pressure rises, cerebral vessels will constrict. Decrease of pH in cerebral spinal fluid by the buildup of CO2. CO2 plus carbonic anhydrase makes carbonic acid. Carbonic acid drops the pH. Causes arterial dilation. Get the CO2 out of there. More oxygen in, get the waste products out. Get it exhaled. Most active regions of the brain must receive increased blood flow due to arterial sensitivity to metabolic changes. The brain's pretty active all over. And if you look at that one video we saw of the monkey brain where they put the radioactive particles in, looking at different shapes, they could see where the activity was. Astrocytes may play a role. They're really not sure about how that works. Generally, the astrocytes there are to support more of your neurons. I'm not sure they've got that one completely down yet. So here you're looking at brain activity and blood flow to the brain. You'll probably be expected to draw this on your... never mind. I'd have to draw it. Cutaneous blood flow. Skin can tolerate the greatest fluctuations in blood flow. Ever been to a burn center? They take skin, they freeze it. And we take it and we transplant it. We use it to cover grafts, use it for burns, and it starts growing. We do it with human skin, we do it with, we put pig skin on just enough to provide protection. Skin helps control body temperature in a changing environment by thermal regulation. That's why when you get warm, you can get red. Your body is opening up the capillary beds. There's something secreted by the sweat glands. What is that? Bradykinin. Yeah, thank you. Secreted by the sweat gland and causes what? Vasodilation. Thermal regulation. It opens up the blood to the skin. You're sweating. The sweat's evaporating. It cools the skin. It cools the blood. It cools the core body temperature. Now, what happens with heat stroke? That shuts down. Your peripheral circulation or your thermal regulation shuts down. Unless they do something very quickly, you can die very easily of heat stroke. Because it's gotten so out of whack, your electrolytes or whatever, that this system simply shuts down. Oh, the bradykinin is already up there. I can see that. Okay, increased blood flow to capillaries. Skin releases heat when body temperature increases. Sweat, aid heat loss. Bradykinin, sweat glands stimulate vasodilation of the skin.
Do you still shunt blood to the skin or vasodilate where the skin maybe becomes 120 degrees outside or something like that?
Sure.
You're going to be...
You just don't feel it unless it's real humid.
Your core temperature is going to be lower than the exterior temperature, though, isn't it? How's it going to cool because of sweat?
Well, if your core temperature goes down, you're not going to shunt blood to the surface, because shunting the blood to the surface is to keep the core temperature down.
But if your core temperature is lower than the outside temperature, whatever.
Well, that's why, yeah. And you know, that's why the Arabs, you see them in the desert, the Bedouins, they are all wrapped up. Because at some point, the core temperature is going to be lower than the outside temperature. And you unwrap and you expose all that blood to the outside temperature, it's just going to bring your core temperature back up.
So there's a point where...
There is a point where you need to stay covered. They say it's kind of the same thing as shaving your dog in the summer. Because, you know, they're designed as a long-haired dog, and it's part of the core, you know, the body's thermal regulation. You start shaving it, you can mess it up. Okay. Cold temperatures activate sympathetic vasoconstriction, tolerated to decrease metabolic activity of the skin. Like I said, we take skin and we freeze it. We freeze it at a minus 50, 60, 70 degrees and preserve it for skin rest. Burn patients. I've seen it in burn patients, and I've seen it in patients that have real bad road rash. Generally, the only few that I've really seen it from there is one fell on his motorcycle and slid he was doing almost 100 when he hit the ground. He slid for almost a quarter mile and took all the skin off his back. So we had to graft essentially the whole back. And the burn patients, and the only other one I saw like that was dragged into a car for 100 yards or so. Hit by a car and dragged. Cutaneous blood flow, ambient temperatures, vascular resistance to the skin is high, blood flow is low. Sympathetic stimulation, again, reduces blood flow to the skin. Do you think that could end up on a test? The 15 or 20 or 30 times we've talked about it. With continuous exercise, the need to regulate body temperature overrides and the vasodilation occurs. Thermal regulation may result in a lower total peripheral resistance, if not for increased cardiac output. What they're saying here is you open up all these veins, you gotta have something to fill them. Either you shut down other arterioles and veins, or you open up and you start pumping blood at a higher rate to maintain the blood pressure. Or, what happens? It's hot, you haven't been drinking enough water, you stand up quickly, or, as I've seen in military formations, they're standing there in the hot sun for hours. What happens? Boom, right over and down. And they drop. Blood pressure gets too low, and you faint. And it can be dangerous. Cutaneous blood flow, I think we've talked about that, arterioles to the veins. Here would be an anastomosis if for some reason the body has shut off blood to the dermis. There's your anastomosis, it shuts it down, it goes right from the arterial artery, not through the capillary, but right into the venule and back into the venous system. Doesn't get to the capillaries at all.
Are those
Anastomosis.
always open?
No, it's regulated. It's smooth, got smooth muscle on them, it's regulated by the sympathetic system for the most part. Blood pressure. Okay, affected by blood volume and stroke volume. What organ is mainly responsible for blood volume? The kidney. From what two systems? Okay, what two hormones?
Oh, ADH and the salt one.
Renin, angiotensin system, and ADH. Yes, you're right, the salt system. ADH, antidiuretic hormone. Reabsorption of water, renin, angiotensin, reabsorption of sodium and salt. When the renin-angiotensin system works, it brings in the sodium and salt and it brings water back in with it. Part of the system. Okay, so blood volume, stroke volume. We've already talked about stroke volume. Increased vascular flow, venous flow. So it's not a huge, but you know, when your heart's beating in exercise, 70, 100, 120 beats a second, even a few mils a beat, your stroke volume goes way up. The amount of blood pumped per minute goes way up. Increase in these will increase blood pressure. Vasoconstriction of arterioles raises blood pressure upstream of the arteries. What do they mean by that? You put a dam in a river, the water rises above the dam or below the dam? Not a trick question.
Back and forth.
Above the dam. Below the dam is where that little stream comes out. So you constrict the arterioles, the pressure is going to go up between the heart and where the constriction is. Okay? Upstream of the artery. Blood pressure, where you put the constriction, you're going to have decreased after, increased before. This could be the arterial, this could be the smooth muscle. Remember, the smooth muscles on the veins and arteries not only run lengthwise, but they run circular around it. They loop, so that when they contract, they can constrict it. In the vein and the intestines, they run the same. They run lengthwise and they run circular, so you can have the peristaltic action. Capillary blood pressure is low because of large sectional area. The vein, the artery comes in, the more it spreads out, the lower the blood pressure because there's more volume to accept that amount of blood. It's kind of like you've got a hose in your backyard and you put your thumb over the end of the hose, it's going to shoot from here to the back of the room. Because it's not spread out, it's going through this one small vessel that you're making with the opening of the thumb. You hook that up to a sprinkler where there's 200 little holes, it may cover an area of maybe 10 square feet. Same pressure's coming out of the hose, same pressure's coming out of the faucet. But what's happened here is you have a large total area that the fluid is flowing out through. In the sprinkler, it's all those little holes in the sprinkler. In the body, it's all the little capillaries. It spreads out. As it spreads out, it takes up more volume, or spreads out into more space, the blood pressure goes down. That's how you keep from blowing your capillaries out. Here, you're coming out of the aorta at about 100 millimeters of mercury. You're hitting the arterioles, you're kind of coming out of the arterioles to the capillaries down here, 30, 35 millimeters of mercury. By the time it gets through the capillaries and into the veins, you're down around 8 or 10 millimeters into the venules. You're down around 2 or 3 millimeters and almost 0 by the time it gets up to the vein cavity. Which is why you need what type of pumps to get it up to the heart? Skeletal pumps. Love it when it starts to come. Kidneys control blood volume and thus stroke volume. Kidneys are going to control blood volume by the amount of water they reabsorb or don't reabsorb. And that is, again, dependent on the amount of antidiuretic hormone. The stroke volume, if you have more blood, it's just easier to fill the atrium and the ventricles, and you have better venous flow. The sympathoadrenal system stimulates vasoconstriction of arterioles. What hormone is that? Adrenal hormone? What hormones are excreted by the adrenal medulla? Epinephrine and norepinephrine cause vasoconstriction, part of your fight or flight. Increased cardiac output. Epinephrine increases the cardiac rate and increases vasoconstriction. Fight or flight. The heart's going to pump more blood. It's not going to pump it to the skin. It's not going to pump it to the viscera. It's going to pump it to the brain, the heart, the muscles. Baroreceptor reflex. Changes in blood pressure detected by the baroreceptors in the aortic arch and the carotid sinuses. The aortic arch on the top of the heart, where the aorta comes out and loops around. The carotid sinuses in here. Now, when they taught you CPR and you went to check for a pulse, where did they teach you not to do it? They don't even want you doing it on one side. Two sides is what they call a brachial rub. And they will use that in tachycardia because of the pressure on the baroreceptors. If the pressure is too high, it's going to say, slow the heart, cut the blood pressure. If you've got somebody that's coding or has low blood pressure, and you're trying to feel to find the pulse, you may actually get their heart to stop.
Where are you supposed to feel for a pulse then?
Wrist, brachial, femoral, not here, not carotid. Even if you're taking your own. I mean, people are taught to do this to deal with a tachycardia.
could also break embolism or something like that.
Well, if you have a plaque buildup, that's usually not in the carotid sinus. Increased blood pressure stretches these receptors. Increased blood pressure stretches the receptors. Now, we dealt with the stretch receptor in the lab a couple of weeks ago. Which one? Patella tendon. A stretch receptor, you hit it with a hammer and it contracted. You're looking at a stretch receptor in the carotid sinus. Increased blood stretches these receptors, increased action potentials to the vasomotor, cardiac control centers in the medulla, drops the blood pressure. Reflex type reaction to a stretch receptor. If you're got high blood pressure, it helps bring it down. If you stimulate it manually on somebody with low blood pressure, you could cause a lot of trouble. You're just looking at the action potentials from the baroreflector. I think they just needed to they had some blank space in there and they needed to put something in. Baroreceptor reflex. Vasomotor center controls vasodilation and constriction. Cardiac controls the heart rate. Via what nerve? Vagus nerve. Do I have to ask you, remember that's the 10th cranial nerve? Or you don't want to worry about it? This is just a diagram of what we've looked at. Fall in blood pressure. Increased sympathetic and decreased parasympathetic. Increased sympathetic. Your blood pressure is going down. Your epinephrine is going to go up. Your heart rate's going to go up. Your stroke volume is going to go up. The vagus nerve will be inhibited because the vagus nerve in the heart slows the heart rate. Again, it's an antagonistic reaction. It goes on back and forth all the time. Fall in blood pressure, increased heart rate, and total peripheral resistance. If your blood pressure starts to drop, as I think I told you right in the first class, the brain's major function is to protect the brain. It's going to do what it needs to do to get its oxygen, to get its glucose, to get its circulation, to thermoregulate itself. The brain is going to, because the brain's the center, the brain is going to protect the brain. Fall in blood pressure, it's going to cut off blood to the kidneys. It's going to cut off blood to the intestine. Falls far enough, you get cold enough and the blood needs to be warm, it's going to cut off the blood to your peripheral system. You're going to get frostbite so that the brain has enough warm blood to keep it going. The brain's protecting the brain. Rise in blood pressure has the opposite effects. Good for quick beat-by-beat regulation. This is your sympathetic or your parasympathetic system. Blood pressure, baroreceptors, medulla oblongata. You either can change the cardiac rate or the constriction, peripheral resistance, cardiac output. It's going to have negative feedback on your blood pressure.
Increased blood pressure stretches the carotid arteries and aorta, causing the baroreceptors to increase their basal rate of action potential generation. Action potentials are conducted by the glossopharyngeal and vagus nerves to the cardioregulatory and vasomotor centers in the medulla oblongata. As a result of increased stimulation from the baroreceptors, the cardioregulatory center increases parasympathetic stimulation to the heart, which decreases the heart rate. Also, as a result of the increased stimulation from the baroreceptors, the cardiovascular center decreases sympathetic stimulation to the heart, which decreases heart rate and stroke volume. The vasomotor center decreases sympathetic stimulation to blood vessels, causing vasodilation. The vasodilation, along with the decreased heart rate and decreased stroke volume, bring the elevated blood pressure back toward normal. If the initial problem were a decrease in blood pressure, the activities and effects of the baroreceptors, cardiovascular center, and vasomotor center would be the opposite of what is illustrated.
Atrial stretch reflexes. In the atrium, you have stretch receptors, and if they feel like the atria are getting stretched, they release atrial natriuretic protein. Affected by increased venous return, stimulate tachycardia, inhibit ADH release. What does that do? If you inhibit the ADH, ADH is what? Antidiuretic hormone. If you inhibit that, what's going to happen? Lower blood volume. You're going to pee out more. Your blood volume is going to go down. Your blood pressure is going to go down. Stimulates secretion of atrial natriuretic protein, or natriuretic peptide, results in the excretion of more salt and water in the urine, affecting the renin-angiotensin system. Again, the goal is to get the blood pressure down. Blood pressure measured in millimeters of mercury by a sphygmomanometer. We did that. We need to go over that again. Cuff produces a turbulent flow in the brachial artery, which you can hear through the stethoscope. The first sound you hear is diastolic or systolic pressure. And what happens? The pressure of the cuff is just as you're lowering the pressure in the cuff, it gets to the point that blood can start squirting through that artery. And that's what you hear. That's the first sound that you hear. If you watch the needle close enough, you'll see the needle start to bounce as soon as you hit your diastolic pressure. There are some people that come in, they have pressure so low, you can't hear it. So you pick it up on the needle sometimes, hopefully. Produces a turbulent flow of blood through the brachial artery. Sounds can be heard using a stethoscope. Korotkoff sounds. Cuff is inflated beyond the systolic pressure. You want to cut off that artery flow, so you don't leave it on there too long. The last sound you hear is when it reaches the diastolic or the pressure is equal between the cuff and the artery. Pulse pressure is a measure of the heart rate. What healthcare professionals feel is increased blood pressure in that artery at systole. Difference between blood pressure at systole and diastole is a pulse pressure. If your blood pressure is 120/80, your pulse pressure is 40. To be perfectly frank with you, I have never heard of a doctor using or referring to pulse pressure. They're looking at your 120/80, and for years and years and years, they didn't worry about the 120. They worried about the 80. Because that's at rest is where your pressure is. And the higher the pressure, the more wear and tear on the arteries, the more chance of arteriosclerosis or hardening of the arteries. It's just like leaving the nozzle on your hose and leaving the water turned on. You'll ruin that hose a lot quicker just because of the pressure and the wear and tear on the hose. It is the same thing with your arteries.
So with the 80 is really low, is that a bigger deal than if the 120 was really low? Like, I mean, not the 80 was really low.
Well, you know, your marathon runners, you see that 80 down at 40, 45. But you see at some point, when it gets too low, you still have a problem where it's easier to throw a clot because the blood is, for lack of a better word, a little more stagnant. So you see a lot of marathon runners that will throw a clot and drop dead, even though they're in better shape than anyone.
That just happened to somebody.
Yeah, it just happened to somebody, but he had a heart defect. He had a murmur that they weren't. That he had had from childhood. When you are in the fetus, you have a shunt between your atria because you don't want to be pushing a lot of oxygenated blood in through the pulmonary artery. And because you want it to go through the mother system, you get your oxygen from the mother. And that shunt normally heals up right after birth. Apparently in this kid it didn't, and they said, oh, you got a murmur, don't worry about it, it'll probably heal, just, plenty of fluids, don't let it gain very excited. And the kid at 13, 14, 15 dropped dead of a heart attack because this one didn't heal and nobody watched it. My 5th grade nephew is going in for open heart surgery in June for the same thing. His hasn't healed. And so they're going to go in and sew it shut. You got to do it. You got to watch it. Average pressure in the arteries in one cardiac cycle is the mean arterial pressure. The difference is significant because it's pressure that drives the blood into the capillaries. Again, I'm not going to make you calculate this, and I'm not even going to worry about it because it's nothing that I've seen a cardiologist or anybody else worry. Hypertension, shock, and congestive heart failure. Hypertension. We'll get through this and then we'll take a break because we're almost done with chapter 14. Is it 14 later?
14, yeah.
Just checking. Hypertension, high blood pressure, 20% of the Americans have it. Increased risk of cardiac disease. Like I said, your garden hose, you leave the water on, it's going to ruin the hose. You leave your blood pressure way up, it's going to ruin your arteries. Increase the risk of cardiac disease and stroke. At some point, you spring a leak, you got a stroke. Hypertension can be classified as essential or secondary. Secondary hypertension, symptom of another disease, such as kidney disease, diabetes. Those are probably the two biggies. Some tumors, aldosterone secreting tumor. You secrete potassium and you reabsorb sodium. Your blood pressure goes through the roof. Secondary hypertension. You're looking at normal blood pressure under 120, under 80 for the diastolic. Hypertension 120 to 139. Stage 1, 140 to 159. Stage 2, 160. You can have kidney disease, you can have artery disease. If your arteries get hard, if you have chronic hypertension, the arteries start getting hard, they lose their elasticity. When your ventricles contract, a lot of the blood pressure is absorbed by the arteries expanding. That's why you feel your pulse. Endocrine disease, excess catecholamines, a tumor of the adrenal medulla, increased cardiac output or increased resistance, excessive aldosterone, aldosterone secreting tumor or Conn syndrome, excessive water retention, nervous system, increased intracranial pressure, Again, it activates the sympathoadrenal system. Cardiovascular, you get a heart block. Ductus arteriosus, you get increased stroke volume, decreased distensibility of the aorta, decreased elasticity or distensibility of the aorta. These are all secondary hypertension. Essential hypertension. Increased salt intake, decreased kidney ability. Now the big thing that's come out in the last few years, when you do a test for a doctor, they all want the GFR, glomerular filtration rate. And they want to see it above 60 mils a minute. They want to know that when they're looking at this patient, that the kidneys are actually working. As you get older, your glomerular filtration rate goes down. You are more susceptible to salt intake. Increased sympathetic nerve activity, increasing the heart rate. They're not sure why. Responses to paracrine regulators from the endothelium. These may be involved in the following. Essential hypertension is where it's not really a disease process, it's just something that's going on. Dangers of hypertension: vascular damage within the organs, especially in cerebral vessels, and leading to stroke. Ventricular overload to eject blood, leading to arrhythmias and cardiac arrest. Contributes to the development of arteriosclerosis. Two, pulmonary hypertension, too much blood to the lungs. Renal hypertension, destroy your kidneys. Ventricular overload, you're getting more blood into the ventricles than can be ejected, or that you lose the balance between the ventricles on either side. And again, like I said, with the garden hose, contributes to the development of arteriosclerosis. Treatments: lifestyle modification, limit salt intake, lose weight, exercise. That damn diet and exercising now. Yeah. Potassium and possibility of calcium. If your potassium's up, when your body is excreting it, it's going to get rid of some of the sodium too. Diuretics, calcium supplements, calcium can act as antagonistic to the cardiac cycle, and so your heart's not beating as hard, brings your blood pressure down. Beta blockers decrease cardiac rate. Diuretics increase urine formation. The beta blockers, beta androgenic receptors, slows them down, slows down your cardiac. ACE inhibitors block angiotensin II production. Angiotensin II reabsorbs salt, brings blood pressure up. Notice, decrease urine formation, increase urine formation. A lot of this is you want to get rid of the salt. Circulatory shock, inadequate blood flow to match oxygen usage in the tissues. Again, the brain is going to protect the brain. First and last, it is going to protect the brain. Your blood pressure is dropping, you're bleeding out, it's going to shut off the blood to the kidneys, it's going to shut off the blood to the periphery, it's going to eventually shut off the blood to the heart, which is going to kill itself, but by that point you're probably gone anyway. Inadequate blood flow and how circulatory system changes to compensate. Your smooth muscles, you're going to shut off your periphery. Your arterioles are going to, the shunts are going to go in, they're going to constrict, they're going to shut off blood to everything but the heart and the brain, and eventually just to the brain. Sometimes it leads to death. We see this all the time. Auto accident, knife wounds, gunshot wounds. The first thing we're going to do is we're going to give them a fluid challenge. We know they're bleeding. We don't know how bad they're bleeding. Doing a blood draw and measuring the hemoglobin hematocrit does not tell you anything in a trauma situation. It takes too long for the body to adjust that. We're going to throw in a couple of 16-gauge bore needles, and we're going to dump saline in as much as we can just to maintain the blood volume. Keep them out of a hypovolemic shock. And saline works just fine temporarily. You know, at that point, then we'll start hanging blood. But initially, you're going to get some large bore needles in, and you are going to get saline in. You're going to get any fluid you can in. In World War II, they found that green coconut milk very much mimicked blood plasma. And in places in the battlefield where they didn't have blood plasma, they used green coconut milk, and it works. Now, the first transfusion was from nobility in Paris, and the guy transfused a guy with sheep red blood cells. Killed that sucker right away. Lost his head for it, too. So, but we talked about that before. But signs of shock: decreased blood pressure, increased diastolic pressure, urine, decreased sodium concentration. Your kidneys are shutting down, you get decreased volume of urine. Blood pH, your alkalosis, due to the hyperventilation, you're hyperventilating because your body's trying to get as much oxygen to the tissue. At the same time, it's blowing off the carbon dioxide. You're going to become alkalotic. Decrease, when you're dying, your pH starts dropping due to the buildup of the metabolic acids. In the old days, I don't know if you ever watch, or at least now they don't do it, House and Grey's Anatomy. You know, you see them doing a code, and it's like, you know, give 2 bicarb. We used to do that to try to counteract that. And they finally decided that it really doesn't do anything, so we stopped it. We don't even have it in there anymore. Poor tissue perfusion. Occasionally warm, dry, they're going to get cold, clammy. At that point, they're well on their way out. Hypovolemic shock, again, same thing. Due to low blood volume, your blood pressure goes way down. Decreased cardiac, you just don't have the blood to push. Diverted to the heart and the brain at the expense of all the other organs. Compensation, baroreceptor reflex, lowers blood pressure, raises heart rate, raises peripheral resistance. You're cold, you're clammy, you're not putting out any urine. You're in a lot of trouble at this point. Septic shock. Little bit different. Your septic shock is because of toxins from the bacteria in the blood. You've got bacteria in the blood. The toxins induce no production, nitrous oxide production. Nitrous oxide does what to the veins? Dilates. The blood pressure drops. Very, very bad. Severe allergic reactions cause an anaphylactic shock. This is due to the histamine. You get, and when you get it severe, I mean, it happens all over the body at the same time. When they started giving penicillin, they didn't realize how many people were allergic to penicillin, even though they'd never been introduced to it. My father was a surgeon in World War II. He would give a guy a shot of penicillin, or he'd seen it happen. He never said he did it. The guy would be dead by the time he hit the ground. He would drop and he would be dead. And allergic reactions can happen that fast. That's rare, but it can happen that way. Spinal cord injury or anesthesia can cause neurogenic shock due to the loss of sympathetic stimulation. I saw a lady once, that was getting treatment in the back, and they put this right into the spinal cord by mistake. They took her, she lost the sympathetic, she was on a respirator for about 3 months before she died. It was actually, I think, when they was first starting to do epidurals, and they got it in the wrong spot. So she had a new baby and never knew. Cardiac failure, cardiogenic shock due to significant myocardial loss. If you lose the muscle, if you've lost because of a blockage, you've had a heart attack, you've lost circulation, your muscle's dead, it can't pump, you've got a circulatory shock. Congestive heart failure, the output does not keep up with the fluid. Similar, we'll come back, we'll just touch on this, but we're running out of time for you to get up to the cafeteria. So let's be back around 8. Take a break. And we will start. That's the last thing this time.
Yeah, and then we'll move on to 16.
And then we'll move on to 16.